Our next lecture is very special. This is the first ever Leuella Klein lecture, which is sponsored by the Georgia OBGYN Society Foundation. Dr. Leuella Klein graduated summa cum laude from the University of Iowa with a BA in 1946 and received her MD degree from the University of Iowa in 1949. She completed training in internal medicine and general surgery. I'm sorry?
Haywood Brown.
Yeah. And, she completed training in internal medicine and general surgery prior to completing residency in obstetrics and gynecology at Case Western Reserve University in Cleveland, Ohio in 1955. After residency, she was a Fulbright scholar and studied in the University of London in London, England. In 1986, Dr. Klein became the very first female department chair at Emory University School of Medicine, and she would later hold the titles of the Charles Howard Candler Professorship. Dr. Klein's subspecialty in maternal fetal medicine served as the foundation for her work as the director of the Maternal and Infant Care Project located at Grady Memorial Hospital, which continues its service to this day. Through her 60-year career, Dr. Klein championed equity, equality in healthcare. She championed care for adolescents, low-income individuals, incarcerated people of color, people with disabilities, people with HIV, and other underserved populations. She was noted for her teaching abilities and her excellent clinical judgment. Dr. Leuella Klein has numerous other accolades, including she was the first female president of the American College of Obstetricians and Gynecologists. She was also the 25th president of the Georgia Obstetrical and Gynecological Society. She was a member of the Institute of Medicine and has had numerous awards honoring her work, including the Arnold Patz Lifetime Achievement Award, the Mary Lynn Morgan Award from the Center for Women at Emory, the Family Health International Distinguished Recognition Award, the Elizabeth Blackwell Medal from the American Women's Medical Association, and the Leuella Klein Lifetime Achievement Award from ACOG, named in her honor. Dr. Klein was a lifelong passionate advocate for women, their babies, and providers who take care of them. In 2018, the Georgia OBGYN Society Foundation established the Leuella Klein Lectureship in honor of her contributions in the continuation of her work. It gives me great pleasure to introduce our speaker for the inaugural Leuella Klein Lecture, Dr. Haywood Brown. Dr. Haywood Brown received his undergrad degree from North Carolina Agricultural and Technical State University and his medical degree from Wake Forest University School of Medicine. He completed his residency in OBGYN at the University of Tennessee Center for Health Sciences in Knoxville, followed by subspecialty fellowship training, fittingly, in maternal fetal medicine at Emory University School of Medicine and Grady Memorial Hospital. Dr. Brown has served in numerous local and national leadership positions. From 2017 to 2018, Dr. Brown served as the 68th president of the American College of Obstetrics and Gynecology. At Duke University, he was the chair of the program from 2002 to 2016. Dr. Brown has previously held leadership positions, including the chair of the Council on Resident Education in Obstetrics and Gynecology, or CREOG, the board of directors for the Society of Maternal Fetal Medicine, and was the past president of the Society for Maternal Fetal Medicine as well. He's the past president of the American Gynecologic Obstetrical Society and the past obstetrics and gynecologic section chair for the National Medical Association. Dr. Brown's additional leadership includes being on the NIH or NIHDC initiative on infant mortality and the HRSA perinatal and patient safety collaboration. He currently serves as the Vice President of Institutional Equity in the Office of Diversity, Inclusion, and Equal Opportunity and the Associate Dean of Diversity at the Morsani College of Medicine at the University of South Florida. Just a few months ago, in April of 2021, he was named the Senior Associate Vice President of Academic Affairs for USF Health and the Vice Dean of Faculty Affairs for USF Health, Morsani College of Medicine. He is an eminent clinician, scholar, leader, and mentor, and he epitomizes the spirit of Leuella Klein and this lectureship. Please join me in giving a warm welcome to Dr. Haywood Brown as he provides his lecture for us, Health Equity in Vulnerable Populations. Welcome, Dr. Brown.
Thank you so much for that warm introduction.
And thank you for all you said with regard to Dr. Klein. It is an absolute honor for me to be giving this inaugural lecture in Dr. Klein's name. As you all know, she was my mentor during my fellowship, and many times in the clinic together were just absolutely amazing. And I would say that she really, really laid the foundation for my career, and really was an inspiration for me to get involved in ACOG and ultimately to ascend to be president of ACOG. And so what I'm going to talk about today really emanates from her whole commitment to one of her biggest accomplishments of ACOG is that she chaired the Underserved Women's Committee for a number of years. And so with that, I want to get started to this today. And also, I want to thank the Georgia OBGYN Society for asking me to do this. I feel like I'm an official member, having done so many meetings, and my only regret is that we could not be in Amelia Island together, enjoying each other's company. You have the objectives, and I'm not going to try to go through them for you. I do have some disclosures. And one of the things I would like to mention is I was just recently appointed the co-PI for the Alliance of Innovation in Maternal Health Community Care Initiative, which is geared toward maternal mortality and morbidity reduction. And we'll talk about that at the end of this presentation. So as you all know, there are a lot of contributors to health and healthcare inequities. There are health system factors, obviously, that we can deal with in our setting. There are clinical and counter issues that we can certainly deal with, including cultural competence and provider communication. There are patient level factors, what their beliefs and preferences are, what their race and ethnicity is, what their culture is, what their language is. We're going to talk a lot about education and resources. And of course, biology plays a role as well. And then our providers' knowledge and attitudes and our commeeting demands and our own biases really play a role in the overall quality of healthcare to women. And this is something that Dr. Klein certainly championed throughout her years, that we needed to literally look at all of these things in order to be able to improve maternal child health outcomes. The things that we're less likely being able to contribute to, and some we can, those what we refer to as social determinants, whether they be poverty. We'll talk a lot about income and how income certainly separates people, unemployment, the stability of housing, food security, racism. Many of these things have been elevated in the time of COVID. So I think you can really see how we're one step away sometimes from being homeless, and we have to begin to kind of think about that, particularly with regard to our own employment status. So this was actually published in December, and it really was the American Heart Association Presidential Advisory, which is a call to action looking at racism as a fundamental driver of many of the health disparities. Now, we know it's not just racism, but this presidential advisory came out of a lot of discussions. And the reason it's so relevant with regard to OBGYN is because I tell people, when you think about prematurity, the uterus is just another smooth muscle like the heart. And when you begin to think about some of this, the factors that lead to higher risk for prematurity and infant mortality and things of that nature, and even higher risk for cardiovascular disease being one of the leading causes of maternal mortality, you have to think about the context of things working in together with regard to inflammatory cytokines and so forth. So stress from being marginalized, stress from having your income being less, are all factors that play a role in disparity. This is a paper that I wrote that was talked about Black women's health and equity and the origin of perinatal health disparities. And I co-authored this, and it was published not too long ago. And it really took a very big look at why are we dealing with certain issues of disparity. And it's really theory. But we really are talking also about generational stress that happens to play a role in these factors. So one of the things I'd like to say that in 1920, there were approximately 1 Black physician for every 3,000 Black people, compared to about 1 in 500 for white people. And so granny midwives attended the majority of all Black deliveries in the former Confederate states. And again, that was what was available, and that was what was done. And of course, when you begin to think about the early 20s, there were many factors going on there that increased the risk for maternal and infant mortality and the disparity for it. What we see here is something very dramatic, and that dramatic issue relates to the 1940s and 1950s, where we began to see a significant drop in maternal mortality. We also saw a significant drop in infant mortality. And so what we're dealing with now is this stable yet rising rate of maternal mortality, where we continue to see decreasing rates in infant mortality. And so what is it that's going on in the life of the mother that really increases these risks in the latter life? And we're going to go through some of those things based on our discussions of vulnerability and who is more vulnerable. So let's talk a little bit about this from the perspective of what happened with the disparity in infant mortality, maternal mortality. And one of the things that we know is that we saw this dramatic drop between 1939 and 1948, when there was a shift from home to hospital births. And maternal mortality dropped by 71%. It actually occurred a little later for Black women in the southern states in the 1950s because there wasn't as great a shift at that time. The other things that happened in 1930, the American Board of OBGYN was one of the first boards, which meant that people were certified to practice obstetrics and gynecology. And then ACOG was established in 1951 when people began to be fellows of ACOG and recognized for the quality of providing care to individuals. So in the mid-1940s, 75% of all Black births were by midwives in the various states. And Georgia, of course, was very similar. You know, one of the things I fondly remember from my days at Grady is a very robust nurse midwifery delivery service to help to handle many of the normal deliveries. Very powerful relationship that's important. The other factor related to perinatal outcome, of course, is the poverty gap. There's a substandard maternal care, perhaps as the origin of some Black maternal and infant morbidity and mortality, particularly as it relates to low birth weight, fetal programming and the thrifted phenotype. And we think about growth restriction. A uterus that's not perfusing well is a smooth muscle. And if you think about hypertension and other factors, these certainly layer on. And generationally, over the course of time, that has its impact. Annual income less than $25,000 and a lower economic educational attainment. These are all risk factors for maternal morbidity and mortality, which makes more vulnerable people at a higher risk. So let's look at it in real time here. This is the relative risk of mortality. When you begin to think about this red line here, this large red line, for people who are 15% or higher, you can see what the dramatic difference in relative risk of mortality is. It dropped down in the 1970s. It really went back up again in the 1990s. We have to concern ourselves with this. And then we've had these big dips. And now we're seeing another dip, increase, of course, in these challenging times. For women who have a poverty rate less than 5%, you can see where they sit on this line. You can see that for people with between 5 and 15%, we sit on this line. And this is why, you know, Medicaid expansion has been such a big, important thing for people who sit between a certain level of income. The working poor has a major role to play, as particularly for women who are adamantly in the workforce and so forth and so on. The other issue that we want to talk about is this was Dr. Philip Lee, who died not too long ago, was Assistant U.S. Secretary for Health and Scientific Affairs under LBJ in 1965. As you all know, LBJ created Medicare, the federal health care insurance program for Americans 65 years and older, which I certainly am a member of that class. It also required racial integration of any hospital that wished to receive Medicare funding. Now, you all remember that Grady was built with two towers. It really was built in an integrated fashion, but was it truly integrated because those two towers were separate and they were absolutely identical? And the same thing with Charity Hospital when I got down there. But by February 1967, nearly 95% of all hospitals were compliant. So Medicare played a major role in desegregation of hospitals. Now let's talk about Medicaid, which also came into play in 1965, and it was designed to provide access to mainstream health care for low-income individuals and families. 32 states adopted this before the first former Confederate state adopted Medicaid. Now think about that from the perspective of Medicaid expansion. And I'll show you a map a little bit that really signifies that. The other thing that occurred in 1920 was the Flexner Report. It decided which medical schools should stay open, and the schools for Blacks and women were not worth saving. 6 of the 8 Black medical schools closed, and the majority of schools that had admitted women also closed. Now think about Dr. Klein, coming on years later, and how this must have impacted her matriculation and her drive and her commitment to get through the things that she got through during the time that she got through them, to rise to the highest level of expertise in her areas and recognition. Also, we recognize the majority of schools offered poor obstetrical training, and they felt that physicians were just as responsible for the high maternal mortality as the midwives. And they encouraged the upgrades of obstetric training for both physicians and midwives. So what do you see coming along later? You see certification in the American Board of OBGYN and so forth and so on. But we still had significant disparities in outcomes in rural America. And one of the things that we'll know now is that 50% of all counties do not have a practice in OBGYN in the United States, 60% of all counties. And so you think about Georgia, you think about rural hospital closures, you think about the impact on populations that are not only less economically advantaged, but also disadvantaged by services and availability of services. So the U.S. has a higher maternal and infant mortality rate than any other wealthy countries, according to 2018 data. The maternal mortality rate was about 20.7 deaths per 100,000 live births. And in 2017, the infant mortality rate was 5.8 deaths per 1,000 births. It was highest in Mississippi with 8.6 per 1,000. So what is the etiology of disparity in mortality, and why are American Black mothers and babies at higher risk than others? And there are many theories behind that. And I'm only going to be able to give you theories, but I really believe that there are many other factors that play a role in this. But we have a role to play as well, as Dr. Klein did. So this is what the data looks like currently. And you can see that, the Black infant mortality, the maternal mortality rate has continued to go up. It reached about, the ratios were here. You can begin to see, this is actually one of the papers that we did and so forth. And you can also see that the Native population, and I'm happy to hear that Dr. Marty Tucker, the current president of ACOG, has a focus on maternal health in the Native communities, including bringing maternal fetal medicine consultation to the Native communities, because you can see that they have the second highest maternal mortality rate and so forth here in the United States. The hidden causes of maternal mortality, the things that we can do in the hospital we have done through AIM bundles. Every hospital must have a hemorrhage cart now, according to JCO. So we've been able to impact obstetric causes like hemorrhage, embolization, if we do SED prophylaxis, preeclampsia, if we follow the guidelines, and of course sepsis, which continues to play a role as well. The things we're less capable of doing are things on the top line. And that is, how do you encourage pregnant women to wear their seatbelts when they suggest that it's uncomfortable to wear their seatbelt in the third trimester, primarily because of the higher rates of obesity in women? How do you deal with the violence and the homicide that really in the domestic violence in the communities that we have to deal with? And then how do we deal with the suicide and the opiate issues, which we have a better handle on now with postpartum depression screening and also opiate programs and so forth and so on. Well, these are factors that contribute to maternal mortality. We can do our part with AIM bundles and so forth and so on in the hospital. But what do we do about these things that are on the outside, that are part of the social factors and the social fabric, particularly that occur in vulnerable populations? And I think that we know that maternal mortality and its preventability relates to the type of things that we can actually have some control over. We can have control over preeclampsia and eclampsia. As Dr. Klein used to say, the patient should never seize while you are watching her. If she seizes before she comes to the hospital, that's one thing. But you and I both know that with us doing 8,000 deliveries at the time, they were often going to seize in the hospital, but they better only seize once on Dr. Klein's watch. Obstetric hemorrhage, venous thromboembolism, the things that we can't do a lot about, like amniotic fluid embolism. But you can see that when we look at the good chance of us preventing a death, there'll be some chance of us preventing a death. And then sometimes we have no chance of preventing a death. And this comes from Elliot Main's data that he published in 2015. Now, this is what concerns me, is when we begin to look at maternal mortality in the United States and compare it to various countries. And you can see Georgia on the map, and I can see North Carolina on the map. And, you know, we hear a lot about Syria, don't we? But when you think about the fact that we can compare, here, it's quite concerning when you begin to think about Syria and Georgia, or Pakistan and Louisiana, or Belize in North Carolina, or Cuba in South Carolina, or Belize again in Florida and in Cuba and so forth and so on. So we have work to do, and we have fragmentation of care, which is very different than many of these communities as well, because you separate the prenatal care from the delivery care, from the postpartum care, and those type of things really further contribute to the vulnerability. The days are gone where someone follows a person throughout their whole practice. When you also look at racial disparity in the big picture, we also have to think about all of the things that are part of this publication that we did with Elizabeth Howell when we were doing the reduction in perinatal and peripartum disparities bundle in 2017. Cultural competence and communication, literacy, language, fragmentation, biases again, comorbidities, interinstitutional differences, education, poverty, institutional racism, environment, where you live, what type of exposures you have, what kind of environmental toxins you're exposed to. All of these type of things play a role in understanding disparity. And so if we had the full answer, many of us would have had the Nobel Prize. And obviously, I don't think that that's in my cards and probably not in anybody's cards in the audience. But we have to continue to explore, how we can tie all of this together if we're ultimately going to impact a racial disparity and improve disparity. So it's not just money, and it's not just race. There are many other factors that play a role when people begin to think about the social determinants. So the U.S. could avoid about 40% of all maternal deaths if all women had access to quality health care. And when I say quality, all care is not quality care, as you all know. We gave good care. We gave good care at Grady. We give good care now. But the challenges of quality care with how there's so much fragmentation really does impact that. And so the U.S. does have a higher maternal mortality rate than many other countries. We have a 2 times greater rate than Canada. But even when we begin to look at people who are delivered in rural communities in Canada, as opposed to people who are delivered in urban centers, we know that there's an outcome difference. Childbirth is the #1 reason for hospitalization in the United States. But the other thing is, for every maternal death, there are 50 to 100 near-miss mortalities. The patient who almost died because of hemorrhage, the patient who almost died because she was preeclamptic, the patient who almost died because she had a PE. And 60% of maternal deaths occur postpartum. It's really more like 50%, considering the fact that we do certain types of things. And then Black women, of course, die at a rate 3 to 4 times higher than that of white women. So one of the slides I showed you was the 40 per 100,000 deaths in Black women in the 1950s and 1960s and so forth. And what are we, well, for women in general, you know, at the turn of the century. But look at where we are with Black women. It really equals that as it did about 50 years ago for overall maternal mortality. So vulnerable health also occurs in the rural communities. And when I say this again, we live in maternity deserts. And you all know what's happening with hospitals in Georgia. We also know what's happening in hospitals in Florida. And again, a recent study of researchers at the University of Mississippi found that more than half of the nation's rural counties had no longer have a hospital obstetric service. And 9% of them lost their services between 2004 and 2014. In many instances, you know, the service that really is giving poor care may be one thing. At least 81 rural hospitals have shut down across the country, and now well over 100. And this was data that we had in North Carolina in 2010. And so it became a real workforce issue for us at ACOG, and something that was been addressed. 15% of the country's population, or 46 million people, live in rural America. So the other thing is that we have dealt with, and we dealt with this in our hospital, we dealt with various hospitals, and that is the prison population of women. We used to actually do a group prenatal care in the prison system in Indiana. And it really was done because the hospital felt very uncomfortable with women coming through the hospital in orange jumpsuits. And so we developed a prenatal care program there. And of course, also dealt with them with triage in such a way that they weren't constantly coming to the hospital. But again, you know, when they did get to the hospital, in many instances, they were shackled. And we do have a person, I remember very well, who escaped from the second floor by tying her sheets together. Because, and of course, she only escaped to her boyfriend's house to smoke some marijuana. And of course, we went there and picked her up and brought her back in. She was in the hospital for preterm labor. That's a true story. The other thing that we mentioned was violence, and domestic violence and homicide. And this has been elevated significantly during COVID, and something that we really talked about. And so when you think about females with disabilities, for instance, this has also been elevated quite a significant amount with violence. Strangers, but look at 16% of that is with a partner. Females without disabilities, same thing. And so we really need to begin to kind of think about the community and our community engagement if we're going to get an impact on all of these issues. And I will share with you the program that I'm dealing with right now, and that is the AIM Community Care Initiative to further reduce maternal risk. So racial and ethnic disparities by state, again, data from Georgia you can see. the levels of the overall levels of highest overall disparity are there in the southern states. And again, you can see that Georgia and Tennessee, but also many of the Midwestern states as well play a major role. And of course, areas of this part of the country as well. If you think about mortality again, we talked about morbidity. And this is not my publication, this is someone else's Brown. But you can also see that Black women have a higher rate of morbidity based on all payers. And it really is not that different than it is with Medicaid and private insurance for that matter. And so what is it again about this vulnerability that really crosses over the socioeconomic, the economic lines? What is that factor that goes beyond payer? And this is something that was just recently published. This just came out in 2021. So it's not just what type of insurance that you have. I used to say to the residents that at Duke, I said, now just because the person has Blue Cross Blue Shield, you want to ignore the fact that her blood pressure is 150 over 100. You can't do that. She's still the same person that you saw in the clinic who had Medicaid and who didn't have any insurance. But just because she has insurance does not mean that she's not vulnerable. And I think those are the type of things that we have to keep in mind. You look at preterm birth and grade by state. Again, we look at this from the report cards in 2020. You can see where you are in Georgia with, that is, the prematurity rates, which is directly related again to entry and stress. If we know that stress puts us at higher vulnerability. These factors play a role. And so you can see that F is not something to be proud of. And of course, we are doing a little better here. I'm not sure what's going on in Oregon, where they get A's, and I want at least be a C. If I can get a C, I'm average, and that is better. The other thing that we looked at is, I mentioned Native women. And you can see that the leading cause for infant mortality in Native women is actually congenital anomalies, unlike Black women, where the highest factor is related to prematurity. And the congenital anomalies really relates to the obesity and diabetes. Obesity and diabetes. You can look at SIDS, you can look at disorders related to shorter gestation, and so forth and so on. And you can also look at, again, violence in these communities that impact child health and maternal health. So the factors accounting for prematurity difference in low-income whites and Blacks are their current health status, their childhood and adolescent health history, the stressors, nutrition, parents and grandparents' socioeconomic status, and quality of medical care during pregnancy. All care is not quality care. All care is not just dipping the urine, checking the blood pressure, and having your hands on the doorknob, which is what we do because we are seeing a patient every 15 minutes. And it really is very difficult to look down with the patient and have them go through all the questions that they have. And I have been the same way. I try to give all of my patients time. But you all know that some patients will take more time than that may be allotted. And that's okay. And I will say that back in the day, I did say, we're going to have to schedule another visit for us to get through all these questions. Write them down, come back in, and so forth and so on, and we'll go through it. But, the whole issue with the CDC is to hear her. And the idea is that we really do want to talk to our patients and talk to our partners so that we can understand what their concerns and their risks might be. So I showed you and talked to you about state Medicaid expansion, which looks almost like it did when Medicaid was established. And I am proud to say that Florida, several months ago, did extend Medicaid to 12 months postpartum. And this was part of a presentation we actually gave to the state legislature, which is bipartisan. We never thought they were going to do it, but they were talking about what can we do to impact maternal and infant health in the state of Florida beyond what we've done. And, you know, they asked a question and we said, we really would see, we'd love to be able to see us extend Medicaid to 12 months postpartum, even though we have not expanded Medicaid. And lo and behold, we have it. But now we have to prove that we can impact diabetes, that we can impact hypertension, that we can impact achieving a healthier weight, that we can impact pregnancy spacing to such a degree that we can improve risk, and that we follow up women postpartum. So I mentioned hospitals. Many of those hospitals that really did not expand Medicaid were in the South and did not, and 82% of rural hospital closures were related to some of that factor. Rural Southeastern communities with measurable health disparities and chronic conditions, diabetes, hypertension, obesity, really are the factors that are geared toward many of the social determinants that we talked about, but also a part of the fetal origins of adult disease. I'm going to skip this one and I'm going to move to this because I want to talk about breastfeeding. And you all know that this is one of the areas that I'm interested in. I've actually worked with Dr. Bugg's wife. Dr. Bugg is a neonatologist currently at Grady Emory. And we've actually increased the number of Black women who are indeed breastfeeding and its vulnerability. But you can see breastfeeding is very much tied to many of the same things, including less high school education, being a high school graduate, and this is how long you breastfeed, and so forth, and so forth and so on. So the rates of exclusive breastfeeding between 3 and 6 months are lowest among Black infants and infants and mothers who are young, unmarried, have lower incomes, were less educated, and were living in rural areas. So one of the correctors of things like hypertension and diabetes and obesity is breastfeeding. And when populations who are at higher risk don't do that, that increases not only their vulnerability, but the vulnerability of their children. So among African-American women, the rates are significantly lower. 58% start out breastfeeding, 28% breastfeed for 6 months, and 8% exclusively breastfeed at 6 months. And the goals for Healthy People to 2020 were actually 82% who ever breastfeed, 61% who breastfeed for 6 to 1, and 4% who breastfeed for a year. So telehealth, telemedicine helps to improve those type of things. This is a program that was actually done in the South, and it's the Communities and Hospitals Advanced and Maternal Care Study, was intended to reduce disparity in breastfeeding initiation and continuation. The results, initiation rose from 66% to 75%, exclusivity rose from 34% to 39%, disparity between Blacks and whites decreased by 9.6% over 31 months, Black initiation rose from 46% to 63%, and Black exclusivity rose from 19% to 31%. So it almost got to what we were talking about with the targets for 2020. And so when you hear a hospital talk about being breast friendly, that only means that they're indicated breastfeeding at the time of discharge. But how many of them are still breastfeeding at the end of 2 weeks? And I think that's really the factor that we have to play up on with our telemedicine and our telehealth outcome. The long-term impact is breastfed infants self-regulate. They have early programming. They have a less adult weight gain, according to a pediatrician in 2010. This is a slide that we will skip through for right now. But also we want to talk about reproductive services and inequity and equality. 67% of Black women surveyed reported race-based discrimination at family planning visits. And so qualitative and quantitative work describes the pressure that many women were felt to be under to choose a LARC method. And so we have to be a little bit careful with that as well. This brings us to the historical perspective that we talk about in forced sterilizations and eugenics. And I won't really go into many details on that, except that almost all states did participate to some degree. And in fact, North Carolina, one of the largest participating states, 31 states had eugenic sterilization programs. Between 1929 and 1974, there were 7,600 sterilizations in the state of North Carolina. 40% were minority women. And most of the birth control pill trials, in fact, were done in Puerto Rico. And also for Native women, the Indian Health Services reported at least 25% of Native women aged 15 to 44 were targeted for forced sterilization to the 1970s. And one other population that we really don't hear much about is the Japanese women in internment camps during the World War II. Fragmentation of care. I've mentioned the fact that 50% of all hospitals provide care for 3 or fewer deliveries a day. So team training and readiness to manage preventable morbidities really need to be able to happen where there's a limited blood supply. We need to tighten the partnership between health centers, clinics, hospitals, and all obstetric care providers, obstetricians, family physicians, nurse practitioners, and midwives. Use more telemedicine, which is one of my task force initiatives. Shortage and maldistribution of obstetricians in rural communities is an important thing for us to keep in mind. And this is the reason I'm excited about the fact that there's a new push to bring back the public health service where people will go to a community in practice and get loan forgiveness. This is a study for rural and urban care looked at in Canada. And you can see the rural people had a higher rates of eclampsia, embolization, uterine rupture than urban women. And infants in rural communities were more likely to have severe neonatal morbidity. Now, keep in mind, this is a country where everybody has some health insurance coverage. What this meant was that providers in rural areas needed to be even more vigilant of the potential morbidity and mortalities and risks. I also mentioned the fact that many of the women have their maternal death between 1 and 6 days postpartum, hence the reason for us redefining postpartum care. More than half of pregnancy-related maternal deaths occur between the date of delivery and dates postpartum. These are things that are really in our control. I would say that these things are in our control as well if we follow the preeclampsia guidelines, if we follow the DVT prophylaxis guidelines. Most of these deaths occurring in this group are from eclampsia and strokes and from pulmonary emboli. So what are the factors for vulnerable women? This looked at 23,000 women on Medicaid. Are the predictors of not attending a postpartum visit were Black race, alcohol and drug use. Sure why that's showing up. Get rid of that. Sorry about that. You may not be able to see that, but I can. Mental health disorders other than depression. Living in neighborhoods where a high proportion of individuals greater than 25 did not have a high school diploma. Again, all of the things that we've been thinking about here that are part of the social fabric versus the environmental fabric and so forth and so on. So ensure that all women are engaged in support they need following birth is essential. And this is why you hear so much about postpartum doulas. But also you got to identify the data with partners. And we actually are doing some partnership programs where we're dealing with fathers, male partners and female partners for that matter, and what their role is in the postpartum aspects of care that can also impact those things. These are things that we're taking up with our Healthy Start programs. We know there's been a decline in suicide deaths as a result of postpartum depression screening. If you don't wait to do it until 6 weeks, the patient's already had issues. We know we need to deal with that. We know that we have a marginalized population who are opiate addicted, and they're most difficult persons to take care of. So early postpartum follow-up and long-term follow-up is critical to prevention of their maternal morbidity and mortality. We need to partner with the clinics that are giving the maintenance therapy. Neonatal abstinence syndrome is one of the leading causes to admission to the NICUs. Labor and delivery management requires special considerations for pain management. These are all the types of things that we have to get into our belly with. And we also need to understand that this model of addiction for opiates is different than it is for any other drug. And think about the perspectives of opiates come in at 4 different areas. And so if people could really, really get off these opiates, many of them really would want to do it. But we know it crosses all populations. And because it hits the centers the way it does, if you can see in this diagram, very different than cocaine, which we came through in our epidemics in the 80s. And of course, with marijuana, which we're learning more and more about. But you can see how opiates come in at multiple different pathways in the brain's interaction. And this is basically opiate addiction, non-Hispanic Blacks, Hispanics, non-Hispanic whites, which have a much higher rate of opiate addiction than non-Hispanic Blacks and Hispanics. Postpartum stress. Approximately 9% of childbirths are associated with real or perceived trauma during pregnancy. It really is a risk factor. And those women who have near misses, think about the fact you have a postpartum hemorrhage and you have a hysterectomy. Clearly, that's going to have some postpartum stress. Preeclampsia, being admitted to the ICU, emergency cesareans, prolapsed cords, flashback, panic attacks, anxiety attacks, extreme fear of pregnancy. Think about diabetes, and one of the things that we don't do well and how often it should occur. And this is one of the things that we have to deal with in our postpartum follow-up. And that is this: the time to developing diabetes. There's been a new study out that says it even occurring earlier now than it did in the past. So up to 70% of women with gestational diabetes will develop diabetes within 22 to 28 years after pregnancy. The O'Sullivans recognized this, and this is the reason we actually did the screen to predict who was going to get diabetes. Progression to type 2 diabetes may be influenced by race and ethnicity and the incidence of obesity, and 60% of Latin women and Native women will develop type 2 diabetes by 5 years after their index pregnancy. This is what bothers me: the lack of screening for gestational diabetes. ACOG recommends that we screen women for diabetes between 4 and 12 weeks postpartum, and then designate how they're going to be followed up, doing a standard test. But even doing a fasting blood sugar helps. But look at the data that fasting blood sugar helps. But listen, looked at 500,000 women across 50 states. 75% had no follow-up screen within 1 year. And in the other study that was published in the Journal of Women's Health, only 23% received any kind of glucose test by 6 months postpartum. That's on us. That's on us. And we have to do a better job at that. We need to follow the guidelines because preeclampsia is a factor for cardiovascular risk later in life. And this is a reason that we need to, ACOG recommends annual blood pressures, fasting glucose, lipids, and BMIs. And this is the postpartum hypertension checklist that was just published in the Society for Maternal Fetal Medicine that you all should have. It talks about patient education, follow-up, remote blood pressure monitoring. So critical factors for us is awareness and assess the risk for pregnancy complications without promoting fear, education of patients and providers and shared decision-making in obstetric care and contraceptive options, awareness of institutional biases that impact obstetric care at any level, that might impact quality and safety. Adhere to best practice guidelines, protocols, and bundles that can reduce risk. Adequately resources for safe and supportive obstetric care, team training, but ultimately accountability. I will conclude by talking about generational stress and the fetal origins of an adult disease that's compounded by many of the segregation practices in the 60s and the 50s and before then, the economic equity, the trust issue with eugenic sterilizations, quality education, and what we can do in our own hospitals to address the factors of bias in the delivery process for all of us and all of our partners. My goal with the postpartum initiative was to have 3-week visits and a 12-week visit. You can see that was published in the May Postpartum Task Force initiative, May 2018. Look at 6 months follow-up for all women with complications, either by video, telephone, or health promotion education. Follow the Institute of Medicine and ACOG guidelines on weight gain and weight loss preconceptionally and interconceptionally. Recreate these guidelines for our colleagues in medicine and cardiology and family practice to recognize pregnancy risk factors. Educate our emergency room colleagues that when a woman presents in 6 to 10 days postpartum with heart failure, that she's probably either got a heart condition or she's got a preeclampsia or many of those factors. Include pregnancy risk factors in the past medical history. Use telemedicine to assist in team-based care in fragmented prenatal, intrapartum, and postpartum obstetric encounters. Health policy, coverage for 12 months postpartum. I know that you all are looking at that in Georgia as well, and I think you got them up to 6 months, and now we need to get them up to 12 months. Seamless handovers of care. I'm right now working with ACOG on a transition to care bundle after discharge. What happens to the patient when she leaves the hospital? Does she get to her postpartum visit? And I'm also working with the AIM postpartum bundle and the community care initiative bundle for what happens in the community as they encounter the social workers and all those factors and so forth. We need to disseminate this to providers, the public, and the payers. We need to monitor and incentivize compliance, and we need to fund research to improve lifelong health in women. And so the Women's Health Research Group is having an NIH conference in October, which I will be participating in. The 3 things that we're most interested in looking at in this is looking at the research around maternal mortality, but also around cervical cancer and this disparity, and also around women with debilitating illnesses, women who are not necessarily disabled, but women with things like lupus, things like myasthenia gravis, things like the types of rheumatoid disorders. And with that, I'm going to stop. I may have gone over more than I wanted to, but I'm happy to be here to answer any questions that you have if I have time for it.
Dr. Brown, thank you so much for sharing this spectacular talk with us today. I know you said you don't think that you're going to get a Nobel Prize, but I certainly think that you deserve one. The Georgia
I can barely hear you. I'm
Society
sorry.
this past year was inspired by ACOG's work in this area and have signed on to the collective action in addressing racism. And I want to just acknowledge your contributions to that and thank you again for leading us and the country in these really important ways. There are several comments in the chat. Dr. Royak, are you available to unmute and kind of bring your comment? I think it's very interesting and timely.
Yes, Dr. Brown, thank you. I always enjoy hearing you speak, and even more so in person, but this will have to do. So about 2 years ago, I received a call from a state legislator.
Could you speak up a little bit? I can barely hear you. I'm sorry.
Okay, let's see. Let's see what I can do here.
It's on my end because the speaker just yes.
Okay.
I'll try to get it. So go ahead.
Okay, so I won't compliment you again. I'll go right to the question. About 2 years ago, I received a call from a state legislator talking about potential increasing role of Medicaid and improving health outcomes in Georgia, perinatal and postpartum outcomes. And I suggested that we try to see if we could get some of our patients to have gastric sleeve procedures. As you know, it has a dramatic positive effect on health afterward, including diabetes, hypertension, maybe even body image, and that sort of thing. So what I know is that these gastric surgeons can do 4 or 5 of these procedures a day. They take about 30 to 45 minutes. So is there any way to push our government to provide for these procedures, especially in some of our patients with extreme morbid obesity?
Well, let me address it this way, because Medicaid does pay for bariatric surgery for people with comorbidities. They did it in North Carolina. They do it in every place. If you establish the fact you have a BMI of 40 and you have a comorbidity, that is something that will be paid for by Medicaid. It's well established. So you don't have to get the federal government to do it. If a patient has it has expanded Medicaid and extensive Medicaid, that's fine. The first thing we have to do is counsel women. We did a study a few years ago that looked at this, where we surveyed physicians. Only 25% of them admitted that they weren't even familiar with the Institute of Medicine guidelines for weight gain during pregnancy. That's a problem. And then the people who were most vulnerable were the individuals who they didn't counsel because they didn't feel that they were going to do anything about their weight, i.e. the biases. And so in my postpartum clinic, we often referred women to the bariatric surgery program. Now, keep in mind, the newest procedure that's suggested is that you go back to Roux-en-Y as opposed to sleeves because of that failure rates. But the bottom line is, if we can begin to counsel women and talk to them in a very kind and gentle manner about their weight, achieving a healthier weight during pregnancy, between pregnancies, improves outcomes. And I can tell you that it works if you sit down and you talk with the patient. And we have to do that. Then we'll say, well, nobody pays for that. But, we don't get paid for the postpartum visit anyway, because it's part of the bundled care. But we got an opportunity to do it. And I agree with you. There are many, many bariatric surgeons who will take care of women with comorbidities because that's what the rule is. So I think that can happen. But it's going to take us to initiate it.
So I agree with you. And, I've had conversations in their 3rd, 4th, 5th month of pregnancy regarding the postpartum period and the surgery. And when someone has bariatric surgery, they typically have to undergo a psychological profile, and they need a few months of counseling before they undergo the surgery. So the surgeons don't want to typically operate on someone 6 weeks after they deliver because they haven't gone through this training course.
I
So
totally agree. Yes.
These sorts of surgeries need to be thought of 6 months in advance and with a reliable payer source. And I don't think pregnancy Medicaid will cover that.
No, pregnancy Medicaid does not cover it. And this is the reason that we have to talk about extension of Medicaid beyond postpartum. And I agree with you, it will not cover that. So this is a longer conversation, but I can tell you that those women, I would be concerned if women did not go through the appropriate amount of counseling that they need. And it's really a very difficult thing for you to do all of that during a pregnancy. You can plant the seed during pregnancy, but you really need to get the person in the psychological state of mind for that surgery to work and to be helpful between pregnancies and so forth. We've done this very well in the infertility population. I used to do a lot of the consults for the infertility groups, and you don't know how many women who were in there with BMIs of 40 who were trying to get pregnant, who had PCO, that would say, we need to get your weight down to so and so forth, and you're a very good candidate for bariatric surgery. And many of them would take us up on it because I would say, who knows, if we were to get your weight down to below 200, you could spontaneously conceive, and many of them did. So I hear you. I think that there are many factors that we can do here that I disclose.
Thank you.
Thank you.
Thank you. I think we'll take one additional comment. Dr. Reed, you and Dr. Baker were kind of talking about the challenges of rural care delivery, and I'm not sure if you just want to bring that up for Dr. Brown's comment.
No, I think this was an excellent talk, and some of the data that you presented is exactly why we now have a District 4 Disparities and Reflective Care Committee in District 4, of which Dr. Green is co-chair, doing a fantastic job. And I think you saw during the break some of the slides that we posted through that committee. But the issue, after 25 years of practicing in a rural community, the closures we're seeing in Georgia are the rural hospitals, which means there's no care in those communities. And physicians are not going to go into a community where they don't have the support they need. And, one of the very first things I said when I came to Emory was that, when you order a transfusion protocol, you need to know what's in the cooler, because if you're practicing in rural Georgia, you've got to order all of that, and it's going to be coming in the backseat of a state patrol car. So there are inhibitions in these communities which are very difficult. And I until we get a rapid transport system in the state of Georgia, I don't see people really being comfortable being isolated in these small communities where they don't have access to what they need in an emergency situation to take care of the patient. So it's a huge issue.
I agree with you.
Broad
keep in mind, you're also in hospitals that do maybe 2 or 3 deliveries a day at best. And, all it takes is one. But it reminds me when I was doing some site visits in South Dakota, looking at their safety programs and their hemorrhage protocols, and there were a number of hospitals that we visited that were really managed by family physicians. They had a robust telemedicine system, and they had a robust transport system. And imagine, you got to be able to get a person out of minus whatever degree weather that's 100 miles away to get them to Sioux Falls. And so they really did a wonderful job with telemedicine and transports, but still they had a lot of vulnerability. It's hard to get people to go to those communities and stay in those communities. And so this is the reason that the U.S. Public Health Service work they're doing about trying to get people to train at federally qualified health center clinics and so forth is going to be powerful in these communities. But we're going to have a transport system, you're right, where we can get people to safe environments. And we're going to have to help people when they're out there practicing. One of the things I loved about the South Dakota system, they had something called e-obstetrics, where you could literally plug into, and they could, it's like, I'll help you do the delivery. I tell you what to do, get the patient ready, and so forth and so on. And that's the thing that I'm looking forward to, that we can evolve to help people. And thank you. The work that you are doing in Georgia is very, very commendable, Dr. Reed. And I know that team very well. And I love being in District 4, and I still see myself in District 4, even though I live in District 12.
We miss you.
Thank you. Well, I was hoping to be able to parlay with you all tonight, but it'll have to happen at another time.
Well,
thank you all very much. I want you all to have a wonderful meeting. And next year, there will be a face-to-face Georgia OBGYN Society.
We agree. We look forward to it. And thank you again so much.